Good morning, everybody. Welcome to YouTube Live, and just waiting for the Instagram to click on, and there we are. Good morning, Instagram. My name is Morgan Denny, and I am lead faculty for the Institute of Clinical Excellence for the PT Daily Show, which is what you're watching right now. Welcome to the late take two because of some technological difficulties this morning. So if you saw this earlier, consider yourself one of the lucky ones who got the original take of this podcast. So as I said, my name is Morgan Denny. I am the lead faculty for Institute of Clinical Excellence, teaching the primary care physical therapy online course, as well as the PT management of the post-COVID patient. These are both online courses available through the ICE website. Today, what I really want to talk about is part two of a long COVID case I started talking about 3 or 4 weeks ago. So I want to do a quick little recap, just a brief one, I promise. But this patient that I started talking about a few weeks ago is a 35-year-old female. She comes in with 3 primary symptoms for her long COVID that started in spring of 2020. So I want to kind of bring you up to speed of where we're at for the things we talked about last time and address there, and then go on to continue to talk about some of the other symptoms and other tests and measures that I looked at throughout time. So last time I talked about and focused on one of her primary symptoms, that was chest tension. So basically this feeling of pressure or tension that came on basically when she was talking, when she was moving, it could even be when she was lying still. And what we kind of looked at and talked about last time, and I encourage you to go back and check that if you didn't hear this podcast, was really looking at some breathing mechanics, some anxiety stuff, things like that. As a bring you up to speed, because now I've had 3 or 4 more weeks of treating her, those have not subsided completely, but they have improved. Our primary treatment techniques have been really working on some breathing patterns and mechanics, as she had almost no diaphragmatic breathing, no lateral rib cage expansion on our eval day, and also really working on some T-spine and rib mobility, as well as some CT junction manipulation has been very, very helpful and really kind of allows her to expand and have a little bit less of that closed down chest tension aspect. So while not all of those symptoms are orthopedic in nature, and some of them are brought on by anxiety and triggering stuff after long COVID, and having had all that inability to breathe for a significant amount of time, she's doing pretty well, which is great because any success you have with long COVID patients is awesome. So that's kind of bringing up to speed on the first aspect. Now, as I mentioned last time, there are 2 other aspects that she brought to the evaluation that she was really concerned about affecting her functionally for her long COVID. Number 1 was head pressure. She described this kind of head pressure as like her head was swollen, her whole face was swollen. It wasn't a unilateral thing. It was generally bilateral in nature, and it could come on with sunlight or exposure to bright light or with talking, walking, but it could also just be present when she woke up. So there weren't any obvious triggers, but there were a few things that we had to work with. In terms of exam, of course, many of you are thinking, well, okay, well, what about her C-spine? Could it be a cervicogenic headache? And I was hoping and thinking that too. So things that I looked at in the eval included doing stuff like, general range of motion, but really the things that tended to be the most helpful in terms of educational for her, or for me, really, as her treating clinician, included that whenever I would palpate her mid to upper C-spine, that would increase the head pressure. Good sign, number 1 in my book. Number 2, when I was kind of testing to see about any strength in her neck, her cervicals paraspinals were not only weak, they were really hypotonous. And for those of you who worked in outpatient ortho for a while, it's the same feel as someone who has had a fairly acute or recent whiplash, where it just feels like the muscles in their neck, front, back, sides, everything is really hypotonous, just like kind of jelly, gummy bear-ish. So that was another major one. And in terms of firing patterns, everything was really delayed and subdued. So there's a big strength component, which is great in my mind, because again, this is another thing that we can affect from the PT side of things. Now, any of you who have taken my primary care PT course are also thinking like, Morgan, headache, head pressure, of course you need to check her blood pressure and her vitals. So I did, don't you worry. And day one at rest, her vitals were pretty good. Like her blood pressure was around 115/72. Her heart rate was in the mid 80s, which is a little bit high, but she was a very anxious person, so be it. And her O2 sats were fine. Respiratory rate was 18. So a little high also, but within the normative range. So check this day one. Now, as many of you who've taken my course are also thinking, but Morgan, we can't just go on resting vitals. We've got to know what happens when this patient moves. Now, I agree that is very important, but because this patient has been so anxious about moving and so anxious about having a setback, she has literally not walked more than a minute or up a hill in the last 2 years. And just as a reminder from last time, this is a patient who pre-COVID was running and going to the gym, working out consistently, but just is so fearful of having a setback and a regression of her symptoms. So day one, we were not able to do any of that kind of stuff, but we were able to kind of facilitate and look at some of this head and neck stuff and see where that might be leading into the head pressure. Now, some of you are probably also thinking, Morgan, haven't you taken Justin's spine thrust course? Like we talk about headaches and how if it is cervicogenic or tension type in nature, maybe applying some manipulation will be good. And that thought definitely crossed my mind. But I'll tell you why I didn't do that day one. First of all, in my experience, a lot of people who have that really low tone hypotonicity and of their cervical paraspinals and also have high level of irritability, especially with like palpation of the upper cervical spine, don't always respond well to manipulation. Now, that doesn't mean it's dangerous, and that doesn't mean it won't be helpful down the road. But with a patient that is new, highly anxious, and we're not sure about all their symptoms 100%, I didn't want to do that day one because if I irritated her symptoms, it would take that kind of a treatment that might be really effective down the road off the table for later. And then she would be like, no, that doesn't work. Remember, that made me worse. We're not going to do that again. So I really wanted to be cautious with how I used that at first. So day one, we didn't do any cervical manipulation. Now, as you'll remember from the last PT on Ice about this patient, we did do some thoracic manipulation, really more to kind of like open up the chest tension. But also when I mentioned that to the patient, she was like, oh yeah, I think that would be really helpful, which is a great sign that the patient, is going to be on board. There's less anxiety about something like this. So I was less hesitant to thoracic manipulation day one. So that's why I didn't manipulate cervical spine. Now, the other aspect of this is that with COVID cases, not just long COVID, but just COVID in general, there's a lot of effects to the microvasculature of people. So while I don't necessarily think that for this patient, there's a VBA or ICA compromise, also without doing some further testing and knowing what her cardiovascular symptoms really entail, it was hard for me to definitively say this is a good, smart choice without having some further testing on board. So day one, no cervical manipulation from my perspective. The other thing is, while I'm hoping, or especially in that day one moment, really hoping that this head pressure, this headache-ness had some form of cervicogenic or tension type headache aspect that we could affect with some motor control and muscle activation and stuff like that. Also, a lot of long COVID symptoms are just due to this ongoing long-term neural inflammation, this delayed and continued cytokine response. So it's hard to say with certainty because there's no algorithm and there's no studies yet, where some of these symptoms are driven from. So it's good for us to keep in mind all of the possibilities and then trial things that feel safe and that could be effective and see how they go. Now, luckily, because now I've had a couple, 3 weeks to kind of see about this, she's actually doing better. The headaches and the head pressure is a little bit less frequent. And when it happens, it's less intense and less in duration. To me, that's a great sign that with just some motor control and strength training for her full neck, we're making a difference. Now, we're not doing anything super significant. We're not doing overhead presses. We're not doing any kind of heavy rows because she is very scared of movement. But we're seeing some progress, so we'll be able to slowly kind of increase that sort of thing. And at least diagnostically, that tells us if the only thing we changed is to add a little bit of muscle facilitation to the cervical spine, that's got to be a piece of it. So sometimes when you're treating, you just have to try something at a low level so you're sure not to irritate people, especially from a long COVID perspective, and then just see how it goes. Does it help? Does it change anything? And use that as some of your diagnostic work. Now, let's come back to vitals for a second, because any of you who have taken the law or the post-COVID course would definitely say, well, Morgan, we know it's super important to screen for cardiovascular compromise, knowing that there are a lot of patients who come out of COVID symptomatic or asymptomatic who have got some form of different heart issue going on, whether they know it or not. And yes, I agree. So lucky for me, after seeing this patient a couple times and she got comfortable with me, I did convince her to try some different stuff. So we were able to do some different positional testing first, because as you can imagine, laying down and then getting up off the table sounded less potentially compromising or triggering for her than doing something active like walking on the treadmill. So we did some positional testing and we talked about POTS, which is postural orthostatic tachycardic syndrome, which is a common thing that a lot of people with long COVID are basically reporting and also then getting diagnosed with. And it involves kind of like an inability for your body to keep up with positional changes in terms of blood pressure that then increases and skyrockets your heart rate. So people report kind of like racing heart and super fatigued after doing low level of activity. My patient had reported like sometimes she felt like her heart was racing or she got dizzy standing up. So we talked about it and I convinced her that that would be an okay thing for us to try. So when we did this, had her just like lie down on the table, supine for a couple of minutes and relax. We took her blood pressure. I don't have the exact stats in front of me, but I'll give you a pretty good estimate. Lying down, it was like 112/72. So pretty close to just her normal resting and within a very normative range. Had her sit up, her blood pressure upon sitting was 114/91. So not a big jump in systolic, but her diastolic went up pretty significantly. Had her stay there for a minute or two, had her stand up. Then her blood pressure went to 115/95. So again, a very small, like 1 to 2 points rise in systolic, which sometimes I kind of say, like, how perfect are we at blood pressure? I mean, we should be good, but how perfect are we? So a very small change in systolic, but again, a small jump in diastolic. Anyone who's taken the primary care PT course would be shaking their head right now and saying, Morgan, that's not what we expect to see. And I agree. So it was really important that we did some of this screening and testing to see that her systolic wasn't going up very much, but her diastolic was. That's not only important for us to learn because of the positional change piece. And actually, it really isn't acting like a normal POTS syndrome where you'd expect to see a drop in systolic. But at the same time, this is important for us to know, because if this is how her cardiovascular symptom is functioning, every time she moves, changes positions, does something, this is an important measure for us to have. Now, as a follow-up, the next week, we ended up doing 5 minutes on the treadmill, which she was really anxious about, but ended up going pretty well. That day when she came in, she was already having kind of a high anxiety day. So her blood pressure at rest was 139 over, I think it was over 85. So that was pretty high for her. And her resting values, every treatment we test them, have been like 115/75, somewhere right in that range. So that day we did 5 minutes on the treadmill. Oh, hold on, let me go back. Her other resting values, I think her heart rate was around 85. Her O2 sats were 99. Her respiratory rate was within normal limits. After 5 minutes on the treadmill, where we just like chatted, she walked at a really relaxed pace, that sort of thing. Her blood pressure actually went down systolic, so it went to 131, but then her diastolic went up into the 90s, or actually no, into the hundreds. I think it was 103. And her heart rate dropped from 85 to 75, with her O2 stats saying the same. So that was also another drop in the bucket, right? Of looking at any change in position, any activity, any movement. Her blood pressure and her heart rate aren't doing what we expect. Her heart rate went down, which in my mind could be because she just relaxed. But her blood pressure, the systolic went down. Again, maybe a relaxation thing, but her diastolic went up. Now, traditionally, scientifically, when we see diastolic go up for people when they exercise, it's usually in people who have high levels of cholesterol and lipidemia, coronary artery disease, that sort of thing, where it's like their ability to vasodilate as their cardiac output goes up with activity is insufficient. But this patient doesn't have that kind of history. So it's, again, important for us to recognize and have these tested measures at hand, because hers could be just bad nervous system training, where her vasodilation isn't occurring because either that neural inflammation around long COVID symptoms could be a heart thing from having COVID. It also honestly could just be a major deconditioning element. Remember, this is a generally healthy 35-year-old that went from being very active to literally doing nothing because of fear and because it would irritate her symptoms. So while I didn't send her to a cardiologist like right out the gates that day, it is always in the back of my mind. And what I want to see is that as we progress and as I get her walking 5 minutes consistently, 10 minutes consistently, we should see her vitals start to normalize in their response to activity and movement. If I don't, that's when I'm going to send her for sure. But it's important that we check these things, because it's not like she said, I'm having heart problems, or I can't walk, or I can't do all these things. But as PTs, this is another aspect of post-COVID care that like we need to get familiar with for sure. So I just want to jump to the last symptom just to talk about that briefly. Her third symptom, the thing she came with on eval, was a visual thing. So she's really having trouble reading. It would cause her some left eye pain and also just make her feel bad, is the only way she could describe it. And she would have to stop. So cranial nerve screen was fine. Should have mentioned that above with headaches, whatever, was fine, except for doing horizontal tracking. Whenever we were coming from the far left visual field back to center, she had a little bit of nystagmus, a little bit of that jump. And once I started working to fatigue that a little bit, it brought on some of her eye symptoms and started to just make her feel bad, whatever that means, right? So I basically gave her day one, just good old follow your finger to the left and back, keep it as smooth as possible. And she could only do 3 or 4 reps of that before her symptoms started to increase. So I talked about before in terms of long COVID, some of these symptoms can be like treating someone post-concussion, where you want to walk them to the edge of those symptoms, but you don't want to go over the edge if you can. And then you want to step them back. So I literally sent her home with the assignment of 2 to 3 reps, 3 times a day. Let's see how you do. And while subjectively so far, her ability to read has not changed dramatically, her endurance in terms of testing has. She can do far more reps going out to left and back in, which makes perfect sense in terms of reading, right? Like all of our reading stuff is left to right across the page. If you can't consistently follow the lines or even skip word to word with recognition, you're going to fatigue. Your eye's not going to be able to do it. So that's actually objectively changing, even though it hasn't subjectively changed yet. But I'm hoping that that will be one of those things that comes along soon. So that's a lot. And I know, and I'm really just talking primarily about eval plus a couple other tests and measures. But I really want to keep talking about long COVID patients for a couple of reasons. Here's the thing. Number one, even since I did this podcast a couple, 3-4 weeks ago, for the first part of this COVID case, our COVID numbers in the States have grown by 10 million, from 50 to 60 million cases in the US. And deaths have gone up significantly. But again, as I talked about last time, if somewhere around 10% of people who get COVID develop long COVID, this is a cohort of people that is growing by the day. And as PTs, I really think we can have a huge effect on these patients, but we have to figure it out a little bit differently. There's no algorithm. You can't follow a chart that says like, day one, do this, if they have this symptom, you do X. But I really think if we're aware of some of the appropriate screening techniques, we can be a really helpful profession to these people, and we're going to start seeing them either way. So we've got to know how to do it safely. We've got to know how to do it effectively. And honestly, we've got to be creative. As I mentioned last time, if you're seeing long COVID patients, give a shout out, send me a message, tell me what you're seeing, because there's no, like I said, there's no write-up about what to do here. And I think the best way for us all to learn is to be sharing stories, figuring out what's working for people. It's not going to be the same, but the more information we have, the more we can kind of gather and gain info and see some patterns start to develop. So I hope that's helpful to you. I hope if some of you are seeing long COVID patients, it's going well. Again, just give me a shout out and let me know. Okay, everyone. Happy Clinical Tuesday. Hope you have a great one. Ta-ta. And there